Hello, hi, good afternoon to every one of you. I hope everyone has freshened up already. We will proceed with the second half of the program today. Next will be my parallel pathway experience. It will be given by Dr. Muhammad Amir Ayub. He is from Hospital Melaka with 13 years of experience in the medical field. He's also the member of the Tissue and Organ Procurement Team and one of the core members of coordinating of procedures and anesthesia in Hospital Jasin. Most importantly, he was once involved with starting up the ICU in Hospital Alur Gajah. Ladies and gentlemen, Dr. Muhammad Amir.
Okay, thank you, Madam Chairperson. There's a lot of history there, though my current work no longer like that anymore. But first of all, can I just have a show of hands again? How many of you are planning to sit for MEDEX again? And then the MCAI? That lone person has died. Okay, but never mind. I mean, there are many paths to the same destination, and we will see how it goes, because in the current climate it's very difficult for you to pursue postgraduate studies. And I will tell you that my own path is definitely not for the faint of heart, because as you can see, it's definitely a road not taken. My only disclosure is that I don't always toe the party line. So hopefully there are no superiors here. But maybe there may be superiors who will be watching on YouTube later, but I don't always toe the party line, so I may contradict what the elders may say. And at the end of the day, how did I end up here? So my life story, okay. So first of all, I was a HKL houseman for 2 years until 2012. And then as soon as I finished my housemanship, I got JKM Melaka. Those of you who know about the history of the state of Melaka would know why I straight away met Datin Sivasakti and asked her to get a red carpet straight into anesthesia rather than any other department. And I did apply for masters in 2013, but at the time I started work 1 month too late, so I didn't get enough SKT in, so not eligible for HLP. And at that time there was some news saying that you could sit for some MCI paper, and I decided to, okay, never mind, just see how it goes. And then what happened was that after about 2 years of housemanship, I sat for the MCI MCQ in Perdana University, and apparently, allegedly, I passed. So what happened next? Of course, there was not much news all around Malaysia regarding what was the pathway like and things like that. And there was definitely not much of social media as there is nowadays, such that you could actually spread information readily from everywhere around the country. And I did try to get some central funding from KKM, but that was not too productive. In fact, when I tried to sit for some local intensive courses, I was told I couldn't join because I was not a master's student. So after that, I did study for a long time alone. Obviously, when you study alone, you tend to have a bit of fear of failure. So it took me quite a while to sit for my next paper, which you can see, because after that, in 2016, I did spend quite a bit of time again and money because of fear of failure. And first of all, I had the MCAI revision course, and then after about a few weeks later, straight away the MCAI OSCE. But the timing, what's up with the static? Okay, but anyway, the timing was a bit near, so I couldn't actually stay in Dublin. Definitely didn't have the money and wouldn't have the leave to stay in Dublin for that long. So I made 2 round trips to Dublin for both the revision course as well as the exam. But what was good was that the revision course basically leaked all the domains that they were going to ask, and that was very helpful for me. And again, I passed. So that was probably another chapter, and me not being very sentimental, that you could see that that was my only picture in Dublin. That was my only picture, which was at the airport on the flight back. So afterwards, there was a further long journey in which I then transferred to HKL in late 2016, because at the time the rules stipulated that you should go to a so-called accredited center, which would be the HKL, Penang or JB or HUKM or UM, to complete your FCI after your MCAI period. But at the end of the day, I was the one and only candidate who actually transferred to an accredited center after the MCI period. So what happened was that with the subsequent journey for all other candidates, they only transferred to HKL after the FCI period, while I was the only one who came to an accredited center after the MCI. So I tried to enjoy all the rotations on offer in the HKL complex without sitting for the exam. But eventually I did sit for the FCAI written in February 2018. And again, I passed, and maybe you may not be able to see it, but the MCQ was a 4, a distinction. So, of course, there was a lot of pressure because my journey was already very long. There was a lot of pressure to actually sit for the FCAI Viva as soon as possible. In general, I still continued my self-study because that was how I studied from the beginning. And eventually I did sit for the final FCI in Dublin in 2019, which I also passed with a 3.3 and 2 score. So what happened in between? There was it's a very long period to consider, between 2013 all the way to 2019. And at the time, the parallel pathway program locally was in evolution, and it probably still is in evolution. And before I sat for the final FCI papers, additional requirements were set by the powers that be locally, and we had the 3-year and post-FCI period, which consisted of 6 monthly assessments. And then you had the directly observed procedures, which you had 10 procedures, which you had to have a proper assessment with observation. And then you had a multitude of case-based discussions. And then you also had thesis. So you had all this. If you thought that the parallel pathway is a way to get away from doing the master stuff, you're probably wrong. And right in between that 3-year post-FCI period, we had COVID. And then we all had those travel restrictions. I was the only one who was in KL. My family remained in Melaka throughout the whole while. And we had COVID. And you could see that in HKL, the burden of COVID was very much a burden, because we had a number of ICU beds that were converted to COVID ICUs. And eventually we did had to convert our GOT to COVID ICUs as well. So how was the COVID burden in HKL? So on top of the patients already in the so-called COVID ICUs, you also had to do rounds outside. And the average number of patients outside is about 75. You probably get around 30 referrals a day, divided among 2 referral MOs. And our record number was, I think, about 70 referrals. We had around 70 referrals for COVID in one day. So if you ideally divided them among 2 MOs, that meant that you were spending less than half an hour seeing one patient. And when patients get transferred out from to the ICU, or patients die in the ward, other patients' SpO2 all picked up because they got their oxygen. So one of the things that people who know me know that I will always say, aku belum mati lagi, refer lagi, because that was just life during those COVID days. So I'm also quite surprised I'm still alive. So eventually, I did manage to pass all 6 post-FCAI assessments with distinction during the 3rd assessment. And of course, I completed all the CBDs and DOPS, and eventually completed my thesis, which was about hip fracture patients in HKL. But of course, this study was done during the COVID period, so there was a lot of problems trying to get the thesis settled. But eventually, it was completed and it was actually accepted for abstract presentation at Korea NS last year. So, how was the journey? So, in summary, each step was completed with a single attempt, but there was quite a long gap in between each step. And early on, there was a lot of fear from failure, which led to stress. And then as I moved to HKL, there was furthermore stress from being away from the family. And then again, your exam, while having to fit in all the other requirements. And then you all had to do this while having to deal with COVID. So since this is an experience sharing session, so I would have to be upfront and say that I'm probably not the typical guy that you should refer to when you want to ask me how do you study, because my study technique is definitely not typical of other people who may be in the master's program. But what I will tell you is that even now as a specialist, I do a lot of long-term studying, and I always do continuous effort to turn my routine work into something that is academic. So everything that I do, I try to relate to something academic to justify all of my actions. So there's a routine review of journals, and I do not have many textbooks, and my real textbook is probably A to Z anesthesia, and that's mainly just to get a brief overview of the topics. And I'm sure that if you all proceed into masters, you will find that the information there is definitely incomplete for you. But if you are taking for MCI, MCQ, is definitely a good stepping stone, because as I will talk later, there are differences in the masters and the MCI program that you need to consider when you want to do your studying. So I classify the way how I study into 3 levels of depth of studying. So of course, whenever there's a case and I plan to do the next day, that I'm almost going to do some ad hoc reading for as regards to a case. So that's my pre-op preparation. And then on top of that, I also have presentations that I want to do, for example, for your department or whatever. So I'm gonna make some notes. I'm gonna make some slides. And then the rest of my free time, I will do note taking, which will be according to a particular theme that I have set in mind that I'm gonna make notes on. And of course, near exam, to be more efficient, then I'm gonna, on top of still doing some notes of topics that are easier to complete, they're gonna be reading further reading of review articles and a lot of listening to podcasts. Because if you're gonna do note taking forever, you're gonna burn your brain. So maybe only a few of you know me, but those who do know that my notes are not for the faint of heart, and they are very quite exhausting to produce. So when I make my notes, I will take multiple references. So if you look at my web browser tabs, there'll be like multiple web browser tabs, and I'll be compiling them all together to make one single note of reference for me. So for example, when I wanted to make my notes on liver anesthesia, so those notes took me a month, because I have other things to study, other things to read, and then whatever free time, then I make my notes, and then I have to go back which one I have incorporated, which I have not incorporated, which part are conflicting, which are the conflicts that I have resolved, and I make my notes. So then I get one particular note but this one is basically on acid-base formula, and hopefully you do not see the curse word as part of the topic, because I'm quite foul-mouthed. So sometimes when I'm stressed, my notes are full of curse words. So if you go to my website there, you can see my whatever notes that I do upload there. So of course, you're not gonna see everything as part of your daily work. So because when you're gonna sit for exams, you're gonna have to study a bit broader, especially if you're taking the parallel pathway, the CAI route. So what topics do I study? What do I base them on? So initially at that time, the Anaesthesia UK website was still up. Every time I try to log in now, the website seems to be down. So I guess that website has completely collapsed. In fact, if you're an Apple user, you would have known that there were data breaches on your passwords there, on whatever lah. So it's probably not a well-maintained website. So, but on top of having topics there and questions there, they actually send regular emails at the time. So I would get past questions, and then of course, based on those past questions, I'd make my studying and my notes. So of course, locally, there's not much of past questions, but at least knowing the breadth of the CII syllabus, whatever past question that I get from anywhere, whether it's master student finals or whatever, I will do some studying based on that. And whenever I decide to make notes, the topic must be something that I can reasonably complete the notes eventually. So I think that liver topic notes was probably the most extensive I've done. Most of the other notes are all completed within a week at least. Definitely not like the liver anesthesia, which took about a month. So of course, along the way, it's not perfect. So I stumbled along the way. There were some topics where I tried to make notes, but eventually I said, no, it's not worth the time and effort. For example, like I was trying to make SUAD notes, and then I also was trying to make PONV notes. You might think that PONV is simple, but when you try to synthesize the guidelines from the American Society of Enhanced Recovery, then you would know that it's actually quite a big topic in itself. So for those topics, eventually I just decided to just read rather than make new stuff. So textbooks. So as I mentioned before, my main textbook was Anaesthesia A to Z. That was the main thing. So whenever I made notes, I would always refer to that first, and then refer to other resources later to make the information deeper. Okay, and then there was also this primary FRCA OSCE anesthesia. I would think if you are taking the CA route, this is definitely compulsory. This is definitely compulsory because when it comes to topics, the OSCE topics, the communication topics, radiology topics, the anatomy topics, they will all actually come out from there, like bulat-bulat. So there were some questions that I did manage to study, but I didn't manage to memorize, and then they all came out like trying to identify the anatomy of the skull vault up and down. So then also the Oxford handbook. Actually, I rarely read this. Just put that there as a so-called third reference. As I said, I'm not that typical, but I do listen to a lot of podcasts. The one on the left is actually the Open Anesthesia podcast, which is mainly related to obstetric as well as pediatric anesthesia. And then the one on the upper right is actually from the University of Kentucky Anesthesia YouTube page. And then the one down there is ACRAC by Jack Walpole. I think he's from California. I think UCSF got. But basically, all three of them are generally American sources. That's generally my listening material. So whenever I do notes, I'm gonna open up my web browser. I'm gonna put in the topic that I want, and then I'm gonna key in BJA, CACCP, PDF, and then see whatever topic comes out, and then open up the tabs, and then read them all. And then also look at the date of their publication, the year, so that let's say if I have any conflicts, I know which one I'm gonna take. And usually I'm gonna take the more recent literature. And of course, in the web, you're gonna encounter material which is not open for you. So there's always so there's a lot of extracurricular activities that I do in the meantime. Staying for 6 years in HKL is quite a long time to be studying alone. And I'm pretty sure some of you who came in earlier saw the original wallpaper. So I used to be a powerlifter. So in 2017, I did compete under the 90 kg class. I'm now much weaker than before, but people tell me that I shouldn't do CPR on patients for their sake. So you can look at the YouTube page there. And then I do gaming. Obviously, as a person that's interested in tech, that would not be surprising. So when I was a medical student, I was actually a packager for an open source game. And then in HKL, I spend my time doing content for another game. But now my personal page is relatively empty as I do a lot of other work. But yeah, that's my channel. So you might be interested, why the hell was I trying to record the videos just now and trying to record all the talks that have been presented today? You may have heard of this channel, the MySigra channel, the Malaysia Special Interest Group in Regional Anesthesia. If you don't know now, today you should know about this channel. And yeah, I am the owner and manager of the YouTube channel. So everything that you see there went through me for uploads, and there are some projects there that we did in-house in HKL. For example, like the fascia iliaca compartment block video. That's probably me, and the video is probably number 2 on the channel. So a lot of other stuff as well, video making, the winning 2021 HKL Anesthesia Day video, that was by me. And then we also did some other informal videos like for our HKL NS clinic. And then those from Ampang will know Dr. Melo. Dr. Melo's farewell video was also produced by me. So, how do I feel about the program? Do any of you know about the Oregon Trail? The trail or the game? Man, you guys are too young. Okay, so anyway, as regards to the parallel pathway program in Malaysia, I am the third graduate of the program. The first one was Indra, second was Amira, about a few months before me, and then subsequently me. And it's definitely the road not taken, and it's certainly not the well-trimmed path of the master's pathway. And like I said, it's still in flux. There's still a lot of debate, like how many checkpoints should it be, how dangerous should the path be. I mean, and is the output from the local parallel pathway even the same as that from the local master's program? And therefore, I mean, you can see that in my time it was different, and then in your time it was different. My time there was no time limit. Now there's a time limit. Which one is for better or worse? Time will tell. Even though we all behind your backs, we all have our debates. So, but what there is no disagreement with is that there's definitely no similarities between the syllabus of the master's program as well as the local parallel pathway, which is based on the College of Anesthesiologists Island. And the way to think of this is that you can think of it as bodies of water, as rivers. So if you take masters and local masters, it's basically a narrow body of water, but it's extremely deep. Deep sampai macam Mariana Trench lah. So because for example, like for your primary, it's mainly almost exclusively physiopharmaco, maybe a bit of equipment. And if you try to study other things, you're definitely gonna fail because you're gonna lose focus on those core topics. And then suddenly when you pass finals, the focus suddenly shift all towards clinicals. But if you take the CI pathway, in terms of the syllabus, it's definitely not as deep as masters. I'm pretty sure that there's very minimal emphasis placed on molecular structures and things like that. Substitution here, substitution there. What happens to the pharmacokinetic? What happened to the pharmacodynamic? What happened to whatever lah? There's very little emphasis on that. But because the syllabus is very wide, so even when you sit for the membership level exams, there's already emphasis on clinical management. There's already emphasis on non-basic sciences. So if you only study physio and pharmaco, you are most probably going to fail your MCAI papers. And what if you are the ultimate masochist? Last time we used to have ANSCA, FRCA in Malaysia, but now no more lah. Last time during my housemanship time, during Dr. Khairul's MO-ship time, there were some candidates who took FANSCA, so New Zealand and Australia. So, but now no more, because we are no longer recognized as a training center, our country. So, and if you want to take FRCA, it's even worse because there was never a way for you to sit for it here. So, of course, I think if you want to sit for ANSCA or FRCA, you are better off trying to think about quitting and leaving the country. So in fact, I think for the FRCA, I think the most contemporary person who I know is a FRCA graduate is Dr. Sharidan, who is one of the regional consultant in Gleneagles, and he is very senior. The other FRCA, Dr. Shanti HKL intensivist, who is retiring. So I do not know anyone who is more contemporary who is an FRCA graduate. But of course, if you let me just be open. So some of the parallel pathway graduates, they decided to quit the program. They didn't want to sit for the post-FCAI period, so they joined IJN. So IJN did send them to England for the FRCA. But at the moment, we have yet to see a true candidate actually pass the FRCA route. So I will just put it as that. So, how about HKL? How many of you are from HKL? Seorang. But how many of you Klang Valley? So most of you know the troubles of living in Klang Valley lah, kan? So there's a lot of good, bad, and ugly lah. So what's good about training in HKL? I think there's undeniable fact that there's a lot that you can learn from being in HKL, because HKL it's a KKM hospital, it's so-called service, but it's very academic in its practice. So you have okay, I'm gonna not curse. So you have a lot of CMEs in HKL. So for example, like on Tuesday, you have your ICU, pediatric obstetric ICU. And then on Wednesday, you have your primary, post-primary teaching. And then on Thursday, you have your department CME. And then if you're doing pain rotation, Friday, you have your pain CME. And then whenever it's convenient, then suddenly Dr. Azrin will call for a regional anesthesia CME. So there's a lot of teaching, and there's a lot of things where you think twice about your management. Everything is like I said, everything is turned academic. And in HKL, there's an undeniable excellent case mix, because there's everything there except for cardiothoracic. Everything is there except for cardiac surgery. So in HKL, there's advanced thoracic cases. So we have been, when I was in HKL, so we have been doing non-intubated VATs. Like even for simple lobectomy surgery, patients are being sent to the ward. They do not need ICU backup. And there are even advanced airway surgeries, especially when Dr. Amir Ayub was around. So doing tracheal resection, anti-sinus surgery. And this is in a center where HKL does not have a bypass machine. So, and we are doing these kind of cases. And you get to see your high level vascular surgeries. So you get to see it because of course when you do something rare like triple A's, so of course they're gonna collect them all in a single center rather than do them in multiple low volume centers. And when you do triple A's in HKL, you will see that sometimes the cases which are stable, they will be extubated. So patients post triple A surgery can be extubated post-op. It's not mandatory that they be post-op ventilated. And because HKL, especially in terms of anesthesia, there's a lot of emphasis on regional anesthesia, and there are definitive benefits for vascular surgeries. So a lot of the fistula-related procedures are done almost exclusively by regional whenever possible. And if you want to see a cell saver, how many of you have actually seen a cell saver? See, so you need to come to HKL and see a cell saver. So because HKL does advanced spine surgery, so for example, for the scoliosis surgery where it's expected to have a high degree of blood loss, so there's cell saver used from time to time. And then sometimes our sports surgeon colleagues do request for RA catheters. So we do oblige and administer them with PCRAs. And of course, there's HKL is a neurosurgical center, and if the procedure doesn't contraindicate extubation, they will be extubated. So there's no reason to think that any neurosurgery must be ventilated post-op. And urology in HKL, Euro HKL is also a transplant center, and we also do robotic prostatectomies. And in fact, if you know Mr. Ashani, so Mr. Ashani himself, nowadays, if you book an ICU bed for his prostate, he will be upset because there's no need for ICU bed for his prostates. So basically, there is an emphasis on providing good anesthesia management, because anyone who has worked in HKL knows that ICU beds are very, 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 very tight. So elective bookings are mainly for cases which they really think is gonna require ICU admission, not really for the what if scenarios. And a lot of times when you say that you have an emergency case, the ICU consultant will just tell you just do and proceed and update later, because there's no way for them to actually guarantee a bed, because HKL ICUs are always congested and full. And because of the nature of the long list, OT list in HKL, majority of the lists are AMPM. So it's easier for you to do pre-med lah, to be in truth kan, because you keluar pukul 2, you buat pre-med, or you masuk pukul 2, you do pre-med before you enter. So you have relatively ample time to complete your pre-med. And there's a lot of RA training with dedicated infrastructure in terms of the logistics to facilitate performance of regional anesthesia. So of course there are pros and cons kan. So what are the bad? So I must say personally, I think that in terms of ICU management, there's a lot of focus on getting the basics right. So they really emphasize mastery of your clinical examination and mastery of conventional things. Conventional modes of mechanical ventilation is especially their emphasis. So you won't see much of HFNC, you won't see much of ultrasound-based assessments, you won't see much of advanced ventilator modes. So there's even very much less amounts of bronchoscopies. So in fact, I have to say that some things do become lost arts when in HKL. For example, like subclavian lines. So in HKL, maybe only the surgeons insert subclavian lines, whereas at least in Melaka lah, the seniors still do a lot of subclavian lines. But of course, the young ones nowadays all do ultrasound guided IJ. Whoever here has done subclavian lines? Zero subclavian lines, as anticipated. So it's a lost art. So what about the ugly? I think those of you living in the Klang Valley definitely agree that working in HKL is for the chosen, because as you can see from the waste map just now, that was at 8:30 a.m. The first challenge is logistics, arriving to work. So arriving to work daily is a challenge. Luckily for me, I did stay nearby in Sentul. But of course, if you're gonna stay nearby HKL, your cost of accommodation is gonna be higher, right? Not gonna be as low as if you travel. So commute. So another thing about HKL, it's huge. It's basically it's a country, and so now you have HKL and then HKL plus HTA. So your main block, your daycare center, your uronephro block, you have your onco block, your neuro block. So many blocks. So now MH and IPHKL, now they have their own new building, which is HTA KL. So basically, there's a huge amount of floor space as regards to the HKL complex. And despite modern times, a lot of areas still do not have good cell coverage. If you work in the A&E OT near the A&E, you're not going to have coverage within the OT itself. So you need to use the cordless phone. If you are in the neuro OT, aka the dungeon, only a few areas have coverage. And if you are in HTAKL, luckily they have Wi-Fi. So you may be able to do your WhatsApp messages. So I think it cannot be underestimated that working in HKL, your ICU workload is a lot. It's a lot. I mean, for me to compare with Melaka, it's uncomparable in terms of the ICU workload. So HKL ICU is a closed system. So in terms of the workload, is about 7 to 8 patients per MO. But of course, you are not going to be focusing just on your patients inside the ICU. You're going to be looking at referrals outside. You're going to be traveling out, looking at referrals, troubleshooting patients already outside, and then coming back and troubleshoot your own patients. So, and then because it's a closed ICU, you are the one that manages the patient. You cannot blame medical. You are medical. So you have to be up to the task of being the ultimate doctor, because you are the one that's making the decision. It's not like an open ICU where you have medical and ICU arguing on the management. No, I think this fluid is too much. No, this fluid too little. No, I want to change antibiotic. No. Now, when it's a closed ICU, you are the decision maker. So you have to be up to snuff with your medical knowledge, as well as whatever your anesthesia knowledge and your critical care knowledge. So in HKL, we have our own dedicated referral MO. Typical, probably around 15 referrals a day. So you can imagine you as a specialist ICU on-call listening to 15 referrals on average. And of course, there are times when the number of referrals exceed 20, 30 referrals. So you can imagine the time spent just for you as a specialist being on the phone and just listening to the case. And therefore, the one you as the MO seeing the referral, you have to be efficient to be as fast as possible. But if you're stuck because there's a crisis, that you are stuck because of a crisis. But if it's just a simple case, you have to be really fast in doing your assessment and your plan and your discussion. So since HKL is a country, so outside rounds are based on areas. Just for comparison, Hospital Melaka. Mana Farid? Farid ada lagi? So Peri round, Aras, berapa patient? 5 juga lebih kurang kan? So kalau ni all block 3 sahaja kan? Maybe. HW 10 maybe lah. So now you imagine in HKL, your outside rounds are divided into folders because you have different states that you need to visit. So last time during COVID time, ED, you had Resus, Amber, ISO 1, ISO 2, ISO 3. And all these areas could have ventilated patients. And then you have your general ward, you have your HW, you have your IPHKL, you have your neuro, you have your Euro-nephro. So like neuro, you can easily have 20 patients in the neuro state for you to review. So it's definitely nothing like comparison with Melaka in terms of the workload. So now you imagine that in the past, before COVID, you only had 2 MOs to do rounds and do rounds for all these patients as a passive call on a Saturday, Sunday. So if you are lucky to have a few patients and a very fast partner, you can finish by 1 p.m. But the typical workload after COVID with 3 MOs, probably 4, 5, 6 p.m. You finish your rounds, then you go back. So, as I said before, HKL it's extremely congested. It's extremely congested, and the waiting time for patients to get out from the ED can take days. The good thing is that critical care starts in ED. Management starts in ED. If the patient needs dialysis, they will be dialyzed in ED. So because of that, whenever there is an empty bed and there is a good case you brought into ICU, that will be given priority compared to other non-acute care cases. So that's why HKL has a zero brain death donation rate, because patients are waiting for days in ED. Sometimes you put the patient on the board, they might be there for 2 or 3 days. So when you actually have a bed, your priority is to bring that patient up, and so that you can actually treat the patient rather than trying to bring any of these potential brain dead patients. So potential brain dead patients are all going to be palliated, whether in GICU or whether in the neuro side. Because even in the neuro block, you're going to have multiple patients who are ventilated in the general ward. because the neuro ICU is full, the neuro HW is full. That's how congested the country of HKL is. So, and so because of that, depending on where you come from, you will see that in HKL there's a large number of people, large number of patients ventilated in the general ward. So it's definitely not going to be like Melaka lah, Farid, sikit je. You have one or two patients ventilated in the ward, then the other primary team bising. In HKL, they have no choice. They're going to be ventilated in the general ward because there's no other place. The limiting factor to ventilate a patient in the general ward is probably the number of ventilators rather than anything else. Because if ventilators are finished, patient tak boleh naik lah. So, has the training been worth it? So I don't know. I'm not that sentimental guy. Only time will tell whether all this time spent in becoming a graduate of the parallel pathway program is worth it. But of course, the question that need to be asked is, am I a quality product and has it been worth the sacrifice? And those are questions that are not easy to answer in the present moment. So, any questions? I think for me, my estimated cost was probably around 50K because during my time, I think the written MCQ was probably about 4K ringgit, and then the OSCE was probably about 5, and then you have to include and then the intensive course was also 5, and then you have to take into account the fact that I made 2 round trips with a stay in Dublin. So you have to take that into account. And then for the final written, I think probably about 4.5K. And then of course for the final viva, there was no choice but to fly there. And that's for me, who has never failed a paper. And with those times fee prices and the currency. Other questions? No. With the parallel pathway of the past, we were not bonded. The parallel pathway of the now, I think if you followed their briefing, there is now a bond. And there is now a tentative period where you have to finish everything. So it's not like before. So can I just have a show of hands? How many of you are 1 year experience? Anesthesia. 1 year. 2 years? 3 years? 4 years? Don't worry. I think the point is that you have to start studying now. I guess that's why you're here. Because you felt like studying. Finally inspired to study.